tuning in, join today's webinar. My name is Sally. I'm the coordinator of the Mind Out project with the National LGBTI Health Alliance, and I'm managing while I'm going, and hopefully that will work. Sorry, so just before we start, I would just like to acknowledge the and to pay our respects to elders past, and I guess when we do online meetings such as this, in that we are representing a space from across Australia to pay respect to all of those elders of all of the lands on which we are meeting today in Australia. Today's webinar, we have Ged Farmer from the Brisbane North PHN, who's going to be talking about the National Suicide Prevention Trial. And I won't go into too much depth because Jed's going to delve into all of that, but I'm particularly excited to have Ged here. There are only 2 suicide prevention trial sites.
Sally, I don't know if you can hear me, but I've just lost you there.
Am I back?
You are.
Excellent. Okay, apologies for that. I'm not too sure what happened there. I think I got kicked off briefly. Hopefully everyone is still here. So I was just explaining, I guess I was excited about this webinar with Ged speaking about the work that's happening in the National Suicide Prevention Trial with LGBTI populations. So just to let people know that we'll be taking questions from today's webinar, and we'll be doing that by the chat box. So there's a little chat icon that you can select, and you can type your message there, and Ged will be answering those questions at the end of today's webinar. So I think without further ado, I'm going to hand over to Ged and look forward to hearing more about your piece of work.
Good morning, everybody, and thank you, Sally. This is my first hosting of a webinar, so please be gentle. I too would like to acknowledge the traditional owners of the land on which we meet. Here in Brisbane, we cross over the river, and so I'd like to acknowledge the Lgbti and the Turrbal people, and the elders past and present and elders emerging. I'd also like to acknowledge the amazing work that the Aboriginal and Torres Strait Islander mental health workers do in our sector. And I'd also like to acknowledge LGBTI elders past and present who have forged the way for so much of the great work that now takes place in our community and has paved the way for some great advancements within our community as well. So today I'm going to be talking about the National Suicide Prevention Trial, and for those of you who don't know about the Suicide Prevention Trial, there are 12 trial sites across the country, and the Brisbane North PHN is one of those trial sites. The aim of the trial is to provide evidence on how system-based approach to suicide prevention might be best undertaken at a regional level and respond to local needs. I'm going to explain a little bit more about that because we use the Black Dog lifespan model to govern the work that we do and guide the work that we do. Part of the trial is also to identify new learnings, and it's particularly important to note that given the new learnings around co-design that have occurred, the cultural safety and integrity and cultural fusion that we've built into all of the processes. So I'll talk a little bit about those, but that has been certainly a very important step in how the Brisbane North PHN has been able to roll out our cycle of the trial. The trial sites will adopt a systems-based approach to the delivery of suicide prevention services. So this is about coordinating a whole range of suicide prevention initiatives right across the sector, and I'm going to explain those in conjunction with the lifespan model. The activities are in addition to the core mental health and suicide prevention activities that are already taking place in the community. So obviously we have a whole range of services that are designated to do suicide prevention work. That work is not that work doesn't change with the trial work going on. In fact, the trial work is designed to enhance those suicide prevention strategies that are already in place. All sites are going to be participating in a comprehensive evaluation of the activities that are taking place, and the University of Melbourne is responsible for doing those evaluations. All sites will focus on activities for one or more of 4 identified at-risk population groups, and I'll talk very quickly about that as well. And just in talking about the coordinated approach, we know that we need to address suicide by having many things in place and having coordinated and systems-based in a way rather than the siloed approach that has certainly happened in the past, where we have emergency departments and hospitals doing one part of that work. We want to be able to coordinate all of the suicide prevention work so that the work that's taking place enhances other aspects of suicide prevention in the community. The National Suicide Prevention Trial has identified 3 priority population groups for the Brisbane North area. So that's the lesbian, gay, bisexual, transgender and intersex communities. And I just want to include brother, boy, sister, girl in there as well. And for those of you who may not know the term brother, boy, sister, girl, that's a term that the Aboriginal and Torres Strait Islander community uses to identify themselves as part of the LGBTI community, and that can be an individual way of identifying as well. We've identified the wider Aboriginal and Torres Strait Islander communities as a priority group, and the other priority group that we have identified is the young adult to middle-aged men 25 to 55 years of age. In addition to that, it's important to highlight that there's part of the work that's being done is whole of population activity, and we have to acknowledge that members of the LGBTI community, the Aboriginal and Torres Strait Islander community, don't necessarily access all of the mainstream services. So it's important for us to have a whole of population approach to the work that we're doing, because people will be accessing services via other means, and we need to acknowledge that there are different pathways to care for different members of the community. So for those of you who don't know about the lifespan model, this is the Black Dog's lifespan model. So I'm going to quickly talk about the different aspects of this, and then I'm going to break this up and then explain how this ties into the work that we're doing. So there are 9 strategies within the lifespan model, and we pull from the strategy where we've identified different pockets of work that need to take place as part of our coordinated approach. The lifespan model, it's a new evidence-based approach to integrated suicide prevention, and it combines, as I said, the 9 strategies that have a strong evidence for suicide prevention into one community-led approach incorporating health, education, frontline services, business and the community. This is a really important aspect of the work that's being done as part of the lifespan model, that there's community drivers that are part of that process. It's based on scientific modelling, and the lifespan model predicts that it can prevent around 21% of suicide deaths and a further 30% reduction of suicide attempts. And Lifespan aims to build a safety net for the community by connecting and coordinating new and existing interventions and programs, and building the capacity of the community to better support people facing suicidal crises. That's another really important aspect of the work that's being done, is to build the capacity of the community. So very quickly, I'll just flip around the lifespan model. So it's about improving emergency and follow-up care for suicidal crisis. This is when people are reaching out for support. Using evidence-based treatment for suicidality, equipping primary care and identifying the support people need in distress. This is where we're working very closely with the health and hospital services to embed good practice and look at the processes that are taking place for people that are accessing accident emergency services. Improving the competency and confidence of frontline workers to deal with a suicidal crisis. This is really important. This is about building the capacity of the workers that are working with people who present with suicidation thoughts and that are presenting to different services. Promoting help seeking, mental health and resilience in schools. This is about looking at what's happening within the school systems. In our region here, we have identified specific schools that we're going into where we know they have high numbers of Aboriginal and Torres Strait Islander students, and where we know that there has been incidents for the LGBTI students in some of those schools as well. The next one is training the community to recognise and respond to suicidality, and that fits in with the campaign work that we're doing, engaging the community and providing opportunities to be a part of the change. That feeds once again into the campaign material that we will be rolling out. Encouraging safe and purposeful reporting of media when we're talking about suicide. So I think most people would realise that in the past, and it is still happening, where often if there's a suicide in the community, the way it's reported obviously can be a trigger for some people. We don't want to be using names. We don't want to be identifying people. We want to report suicide sensitively. So part of the strategies is looking at ways of upskilling and building the capacity of our media outlets and any reporting that takes place for suicides within the community. And improving safety, and this is about reducing access to the means of suicide. So I'm just going to break up that a little bit and just explain a little bit more around the work that we're doing and how that work is being done and who's doing that work and what the actual work is. So you'll see that we've sort of chopped up the pie of the lifespan model here to break it down into the areas that we will be looking at. Now, obviously, we're not doing all of the components of the lifespan model in the trial from Brisbane North, but all of these are interrelate and are part of that systems approach to reducing suicide. Important to highlight that the work is governed by data-driven information and also lived experience. So we have many people with lived experience that sit on our implementation groups and our steering committees, and we also work very closely with organisations that have a lived experience peer-based model as well. So some of the work that's being funded, now it's important to highlight the intersectionality that occurs within the LGBTI community, and given that the Aboriginal and Torres Strait Islander stream is part of our priority groups, we know that there's an intersectionality that exists for LGBTI people that identify as Aboriginal and Torres Strait Islander, and once again how there's that crossover of intersectionality between those communities and how people exist within those communities as well. So starting with those two aspects of the lifespan model, within Aboriginal and Torres Strait Islander communities and LGBTI communities, the funded activities are going out to two agencies. So here in Brisbane, we have an Aboriginal and Torres Strait Islander agency called Kabingai, and we also have an agency called the Centre for Human Potential. The Centre for Human Potential works in partnership with two of our other important agencies here, which is the Queensland AIDS Council and Open Doors Youth Centre, which are both LGBTI agencies as well. So what's taking place here is this is a referral point for people that present in crisis and have that emergency and needing follow-up care. So both of these agencies are doing that, and this is around using evidence-based treatments, So each of these agencies use psychology and also used evidence-based programs, group programs, to work with the community in addressing suicide within the community. So the emergency and follow-up care that I mentioned, which is being done by Kabingo. So at the moment they take referrals. Those referrals can come from anywhere within the community. What we are seeing for the Aboriginal and Torres Strait Islander community is that many of the referrals are coming from the community, where people might go and speak to an elder, for example, in the community before they access one of the services within the community. And then that's partly why we want to train up elders around those pathways to care, and I'm going to talk a little bit more about that as well. The other pathway to care is through the Centre for Human Potential. So the Centre for Human Potential have their own psychology services, and they also partner with Queensland AIDS Council, so people can access services within that LGBTI safe environment. And for young LGBTI people, we have psychology and case management services operating out of Open Doors Youth Service. The other aspect is the frontline worker training and the gatekeeper training. So just a little bit of an explanation about what they mean. The frontline worker training is using a higher level of suicide prevention training. So for example, assist training is one of the evidence-based models that are being used. And so frontline workers in those agencies are being trained, but frontline workers in other agencies that we know are access points for the community are being trained using assist or another evidence-based model to train up the workers. The next term you see down there is gatekeeper training. So there's a little bit of, I guess, uneasiness within the community to use the term gatekeeper training, and I think most people feel more confident with using a term like connector or, you know, those key people within the community. So some of the examples of gatekeeper training are, you know, training elders. So we know people go to elders within the Aboriginal and Torres Strait Islander community, and also within the LGBTI community, people will go to those known icons and those known people that are the connectors within the community. So we want to train those people as well around how to have those conversations about suicide, how to access care, and how to be able to engage with people so that the conversation continues, because particularly for the Aboriginal and Torres Strait Islander community, there can be barriers around how those conversations take place. The correct language and cultural safety and cultural integrity is absolutely paramount around how people talk about suicide within those communities. So the agencies that are rolling out the frontline worker training and the gatekeeper training are Kabingo. So Kabingo are rolling that out for the Aboriginal and Torres Strait Islander community. And for the LGBTI community, we have Diverse Voices are rolling out that training. So Diverse Voices have already started rolling out that training. They've been rolling out assist training as part of that, and they're looking at some other models. So for frontline workers, that's the 2-day assist training, and so obviously that means taking workers offline for 2 days. And when we're talking about the gatekeeper or the connector training, we're looking at some other models such as Calm, Safe Talk, those types of other suicide prevention training models that can go out into the community. I guess an example for the LGBTI community is, who do we train in that community? So we have some social groups. So obviously we want people that are running those social groups to have suicide prevention training and have that knowledge. And then it goes further out to where people are accessing you know, their social networks and that type of thing. So we'll be training, for example, bar staff within some of the community, some of the venues that exist here in Brisbane. We know that it's often, you know, somebody like a bartender, where people will sit at a bar and have a chat, and then when they're feeling a bit more comfortable, might start to talk about some of these intricate conversations and what's happening for them. So we want those people that are those connectors in the community to have a really good knowledge around suicide prevention, knowledge around the pathways to care, and knowledge around how to have those conversations safely so that they can engage with people and have that language and that sensitivity around having those conversations. The next aspect of the lifespan wheel that I'm going to talk about is the help-seeking mental health and resilience in schools. We have two agencies that are undertaking that work. We have Y2K, so they are an Aboriginal Torres Strait Islander agency, and the work that they're doing is around reigniting culture and reconnecting to culture. We know within the Aboriginal and Torres Strait Islander community that culture is so important, that for many people that have been disengaged from culture, that reconnection to culture is a healing tool in itself, so that, that reigniting of culture. So Y2K are going into 6 of our schools here in Brisbane, and these are schools that have high numbers of Aboriginal and Torres Strait Islander students. It's a 4-week program, and over that 4-week, they look at connection to culture. They look at some health aspects, so they look at health aspects around mental health resilience, drug and alcohol, pathways to care, so working with the students around what are the pathways to care if, one of their mates or somebody is talking to them, another peer from the school is chatting with them. And also looking at the cultural sensitivities around accessing suicide prevention within the community as well. The other lead agency that's doing the LGBTI work is Open Doors, and Open Doors are going into some designated schools where we know there have been issues around suicidality and impacts for LGBTI students within those schools in Brisbane. So some of the work that Open Doors will be doing will be around building the capacity for students and those networks within the schools, building that capacity for teachers, and setting up safe networks and champion networks within those schools as well. Part of that work will also be around setting up some social networks for the students that are connected with those schools, and providing opportunities for LGBTI youth to be able to connect with other LGBTI youth within the community. Open Doors has their own space, so that can be a referral pathway into that service as well. They'll also be looking at things like rolling out inclusive services training into the schools, and assisting those pathways to care for teachers and guidance counsellors and school-based health nurses, that type of thing, who will be making those referrals into those services such as Open Doors, the Centre for Human Potential. It's important once again to acknowledge the intersectionality and the crossover for LGBTI students who may identify as Aboriginal and Torres Strait Islander and vice versa, and that connection to their networks that they have. So we know that there's that connectivity that young people have, and how that sort of stretches across their networks, and that's part of the work that both of those agencies will be doing, and in particular, Open Doors will be looking at how they can strengthen those networks for young people within the community and within those schools. The other aspect, and this is a really exciting part of the work that we'll be doing, is the community awareness campaigns. So the agencies that will be rolling out the community awareness campaigns, we have some Aboriginal and Torres Strait Islander community agencies, the Garbunjalam Network and Indigenous Women's Leadership and Support Group. So they are rolling out the awareness campaigns for the Aboriginal and Torres Strait Islander LGBTI brother, boy, sister, girl communities within the Brisbane area. And for the LGBTI work that's going to be done, once again, there's a connection with Gabunjalum Network and the Queensland AIDS Council. So the Queensland AIDS Council are rolling out that work, but they're working very closely with the Gabunjalum Network, once again, around cultural sensitivity, cultural integrity, and cultural infusion into all of the work that needs to be rolled out. The other important aspect to highlight is, once again, that lived experience. So Roses in the Ocean play a large part in that. So Roses in the Ocean are a lived experience of suicide organisation. They sit on all our implementation and steering groups and guide that work, and will also be training people in the community to be able to safely tell their stories, have that knowledge around the type of language to use, and also to be supported in a way so when people are sharing their lived experience stories, having an agency like Roses in the Ocean to support those people and to be a part of that, and they will be providing training for community members. We also have Queer Radio here in Brisbane, so 4ZZZ have been part of that process as well, and so they've been rolling out some of the messages. We've been able to do interviews on 4ZZZ to be able to talk about the work that we're doing. I want to talk about very quickly one of the really exciting aspects of the work that's happening that has occurred, and that has been where these contracts have gone out to community groups. So this is a bit of a first across Australia, where normally people assume that the lead agencies that are already doing this work within a community, that's sort of where tenders normally go to, or where contracts are normally awarded. With the National Suicide Prevention Trial here in Brisbane North, we've taken on a different approach, and so we had a lot of community consultation take place. We then had those community members, those community organisations, as part of the guidance around where those contracts should be best placed, and where that work is going to be generated from. So it's really exciting that the Gabunjalum Network and Indigiles have been awarded contracts to deliver the work here across the Brisbane North area. They are auspiced by the National LGBTI Health Alliance, but it's sort of a first for this type of work, where community groups are now driving the work that's being delivered, and it's important to highlight there were some really strong cultural processes that took place. So our local elders were involved in all of those consultations. At certain points, we understood that there were some cultural discussions that needed to take place, and during those discussions, the PHN allowed those discussions to take place. So effectively, PHN left the room while some of those cultural discussions took place. And here we sort of are with some great synergies occurring across the community with community groups and some of those lead agencies that are now delivering the work. I'm just going to talk very quickly about some of the whole of population work, and this includes Aboriginal, Torres Strait Islander and LGBTI communities. So as I mentioned before, it's been really important for us to acknowledge that the networks that people sit amongst don't necessarily go where we would assume they would go. So members of the LGBTI community, not everybody's accessing LGBTI support groups or community groups or LGBTI venues, or necessarily reading LGBTI press. And similarly for the Aboriginal and Torres Strait Islander community, they're not necessarily accessing Aboriginal and Torres Strait Islander designated services. They are accessing other services as well. So much of the work that we have also rolled out has been to look at that whole of population work as well. Some of the whole of population work that has been funded has been the AIS through AISRAP, and that has been the STARS training that has been rolled out, and this has been rolled out to hospital and health services, many of the agencies and the psychology services that are rolling out that work. Agencies, for example, Partners in Recovery agencies that are rolling out that work as well. We've been doing GP training, and this has been run through Wesley Mission Queensland, and that has been rolled out right across the sector. So we're capturing that whole of population, and then that also creates better pathways to care for people that are then accessing services amongst those other priority groups that I've discussed with you today. The last part of the work that I want to talk about is the media work and the guidelines for safe and purposeful reporting. We would all know that we've experienced some pretty horrendous stories that have been discussed within the media, and often those stories, as they're broadcast or disseminated amongst the community, are quite they're quite emotional for people. They can be triggers for people. So we want there to be really good guidelines around that. So we have Mindframe Plus, who are rolling out those strategies for the community. They are running training for media outlets. They advise when media outlets are going to run a story, they can proof stories, they can advise how a story can be told in a safe way, and also advise what the safe language is that should be used when we're reporting. And I guess it's important to acknowledge that that sort of goes for all of us around the language that we use when we're talking about suicide and trying to embed good suicide prevention strategies into the community, that we are very mindful of the language that we use. So if you go on to the Mindframe Plus website, you'll be able to download many resources that will be able to help you with this. There are some great handouts that I'll often use at meetings or at different events. I'll hand these out so that people are aware of the language we want people to be using in those frameworks. So we've run a series of community consultations, and we've always set the beginning of those meetings and consultations by talking about the type of language we will be using and the type of language that we feel is maybe not appropriate in that setting, because often there will be people that have a lived experience of suicide that are part of those community consultations. So you can see in front of you there are some different guidelines there. So a great example is, the issue language that presents suicide as a desired outcome. So we've often heard things like successful suicide or unsuccessful suicide. That is obviously problematic language, and that's not the type of language we want to be using in our day-to-day discussions around suicide prevention. So we use preferred language such as took their own life, ended their own life, or died by suicide. I'm going to run through the others because I think it is really important to talk about that. Phrases that associate suicide as a crime or a sin. So the term committed suicide or commit suicide, once again, it's a term that we find problematic. So the preference is to use terms like died by suicide or took their own life. Language that glamorizes, so failed attempt or suicide bid. They're the type of phrases that we are really trying to steer away from and stop using those types of things in the community. So made an attempt on their life, a suicide attempt or a non-fatal attempt is far better than using a failed suicide or a suicide bid. Phrases that sensationalise suicide. So we often hear media using terms like suicide epidemic. We'd rather use terms like higher rates or increasing rates or concerning rates, so that we're talking about the story, but we're not putting that, that sort of slant on it that starts to, make the language uncomfortable for people to be using. and terms like suicide missions, political suicide, suicide pass in sport. We want to refrain from using any of those terms around suicide that are often, being used in an ambiguous way. But once again, just using the term suicide, we have to be mindful that in most settings within our community, somebody, it could be a trigger for them, or somebody's been affected by suicide within the community. That's the end of my presentation and the overview of the presentation that I'm doing today. So I'm going to hand over to you for any questions and discussions and any comments around the work that we're doing here in Brisbane North.
Great, thank you so much, Ged. So please just use the chat box icon there to type any questions that you might have for Ged. I guess while we're waiting for that, Ged, I'll ask, is it okay if I ask you a question?
Yeah, of course.
I guess I'm wondering about what has been the biggest challenge to date in this suicide prevention trial, particularly working with particular priority populations and intersections with those priority populations. What are the challenges been?
Yeah, so there's been multiple challenges that have occurred, and I guess one of them is that political challenge around meeting the demands of the guidelines. When any funding is rolled out, you're given certain timelines to do the work and that type of thing. We certainly know that with co-design you have to get it right, and some of the challenges that we experience, particularly when putting together the work around the Aboriginal and Torres Strait Islander community, was allowing for that to take place. Allowing for good timelines so that we got it right, and taking a step back when we needed to as well. So that's certainly been one of the challenges has been around those timelines. And so one of the really strong comments that we've had back from the Aboriginal and Torres Strait Islander community has been allowing us to take the time needed to get it right, rather than pushing something to serve an agenda rather than serve an outcome. And so that's certainly been a challenge. Obviously, there's been cultural sensitivities for the Aboriginal and Torres Strait Islander community and the LGBTI community. And like you sort of said before, Sally, some of that intersectionality, that crossover and those sensitivities that can occur for people that exist within multiple communities or have multiple cultural identities, if you like. So, somebody might be Aboriginal or Torres Strait Islander, they're LGBTI, they may have a disability or other things going on for them. And then, making sure that the processes that we're using aligns with that and the sensitivities that need to happen with that as well.
Great, thank you. Kerry has got a question. How do you liaise and work with people who present to the emergency department with suicidal ideation?
Yeah. So I guess there are several layers to that question, Kerry. So as part of the work that we're rolling out, so obviously we are a commissioning agency, so that work's being done by agencies, but we have run some fairly extensive consultations with people that have accessed emergency departments around suicidal ideation, and those people with that lived experience have really helped us generate the direction in which some fairly important changes need to take place with accident and emergency department. In the consultations that I've attended, that would have to be, one of the highest issues on the list is the many complications that occur. So firstly, you're presenting with suicide ideation, and obviously some sensitivities need to be addressed around that from the people who you're first seeing when you go into an accident and emergency department. We know often there are really long waits in accident and emergency departments, and often people unprepared or emotionally ready to sit there for 5 to 10 hours waiting to be triaged. So we are working with hospital systems to look at better ways of triaging people and making sure that people are safe when they access accident and emergency departments. One of the projects that has been going on around the country has been the Safe Space project. So when people are presenting at emergency departments, instead of being made wait in the emergency department waiting room, they are given another room to be able to sit and wait and have somebody there to talk to. So this is where some of that peer work has come into play really strongly, where we have peer workers and people with lived experience of suicide who are able to be there in some of those settings. So, there's no hiding that we have a long way to go with hospital systems. Hospitals are under a lot of pressure around the amount of people that access emergency departments. Upskilling staff has been a critical element around how people can present and be treated respectfully and have the right outcomes, because we know often when people don't understand the dynamics that are occurring for somebody who is presenting in this way, how they should be treated, what are the conversations that need to be had. One thing that seemed to come up at most of the consultations was, people are presenting to accident emergency departments and they're having to tell the person at reception what's going on for them, and they're speaking quite audibly so other people in the room can hear. So obviously we want better systems in place where people can be treated sensitively. It may not be appropriate to be standing at the reception area telling your story or trying to explain what's happening for you, and then having to give all your personal information when you're already quite stressed. So there's a whole lot of work that's happening around that area, Kerry, and hopefully this is the pathway to some better outcomes for people that present at emergency departments.
Right. While we're waiting to see whether anyone else has any other questions for you, so if anyone has any questions, please just type them in the text box. Another question I have for you, Ged, is were there things you've done differently with the LGBTI community in implementing this than you have with other populations? Is there something, I guess what my reflection is it something you've had to do differently to take into account the particular needs of the LGBTI population?
Yeah, absolutely. And so, one of the important approaches that has happened, particularly around implementation and consultation, has been to work from community up and from culture up. So, culture needs to be embedded into all of the work that we do. So the work that we do starts with culture, and we include elders from the Aboriginal and Torres Strait Islander community and key people from the LGBTI community into those processes. We haven't gone down those traditional approaches where we're typically using, as I said before, the mainstream agencies that have always done that work. We're going to that grassroots level. A great example would be Indigenous and Gabunjalam, where we're working closely with those groups. So they're Aboriginal and Torres Strait Islander LGBTI groups. Groups like the Wendy Bird, where we know that they're important connections for people, where people are connecting to their community. Often that's the point where people want to start to connect with other people into the community. So working with community groups, working with people with lived experience has been something that I think has been really important in what we've done differently.
Great. And I guess also I'm curious about what are you, at the end, because I know you're still partway through this. This is still a work in progress. You're sort of partway through the deliverables and a whole bunch of things are happening. What are you sort of hoping to achieve or learn or to happen at the end of this project? what do you hope to get from that?
Yeah. So obviously the outcome is to have a reduction in suicides occurring within the community. That's obviously our priority, and making sure people are getting better care and have better pathways to care. We want to enhance those pathways to care because often people don't even know where to go to, and so having really good pathways to care is something that is already happening as part of the trial. So that's part of the work that's happening. Having people better connected to their communities and to their family, raising awareness and being able to have the conversations within the community. They're some of the really important achievements we want out of this. A really big thing is that suicide prevention needs much more funding, and we want the trial to be able to give the evidence back to the government and say to them, these are the strategies that we know are working within the community. These are the things we know we can do to reduce suicide and suicide attempts within the community. Part of that legacy is having better systems in place, but having the government listen to what we know works, what we know is best practice, and what we know needs to happen within the community. So, I could probably sit here for an hour and talk about all the things that we want to see come out of the trial, but like I said before, obviously suicide reduction is paramount for us. Particularly for the Aboriginal and Torres Strait Islander community that has the highest rates of suicide in their communities across the country. The LGBTI community, which has incredibly high rates of suicide within the community. So we want to see those rates reduced, but we want to see better community responses to preventing suicide within the community as well.
Great. Thank you so much for that, Ged. And I would echo that as well. I think the opportunity of Brisbane North PHN and also with Northwest Melbourne PHN focusing their work in the National Suicide Prevention Trial on LGBTI populations has actually given us a rare opportunity to build that evidence base, to learn from direct practice about what are the strategies that work for our communities, but that are led by our communities and informed by our communities. So I think, and that's one of the reasons I want to showcase the work that you are doing, because I think it is one of these really rare opportunities that we've had to see this investment in LGBTI suicide prevention, but this investment also facilitates this place of learning and building of evidence that will then go on and inform future work. So I wanted to...
Well said. Yeah.
Yeah, so thank you, Ged, for sharing your knowledge and wisdom today. Oh, another question from Kerry about, have you set up specific services interventions?
I guess, in sort of reflecting on the overview of some of the work that I discussed before. Just the fact that we have some very specific services doing this suicide prevention work, where before it wasn't necessarily LGBTI agencies that were doing the work. So there's been some very specific psychology services set up targeting the LGBTI community. There's some great resources that are currently being produced at the moment. So there will be, some things that create a legacy within the community around how we communicate, how we become more aware of suicide within the community. And then I guess, in the sense of follow-up care, part of the strategies for the agencies that have the contracts around that. So we call it emergency and follow-up care, and the follow-up care is part of that aftercare that you're asking me about, that will be occurring. So we know when people present, for example, at an emergency department, that first 24 hours is absolutely critical, and then the next 7 days is absolutely critical. So the aftercare that people receive after presenting with suicidal ideation is absolutely critical. So there are much better services that are being created amongst the community for follow-up. there are systems in place. So, you know, one of the agencies talks about certainly the response time, which must be adhered to, and then those follow-up markers that are absolutely paramount. So they're flexible, obviously, those follow-up and aftercare markers that need to occur. But what's happening is people aren't, you know, seeking a service and then being put back out into the community without any backup. That's probably one of the important things that has happened. Your question there is that Artius. No, Artius aren't one of the organisations contracted as part of the suicide prevention trial. So the Centre for Human Potential do the follow-up and emergency care, the emergency and follow-up care for the LGBTI community, and Kabingai are doing the Aboriginal and Torres Strait Islander. And then there's that crossover. So they refer right across both of those agencies, because we know an Aboriginal and Torres Strait Islander person may need to access a mainstream service because of some of those cultural challenges that might occur. Often people know people that are in those agencies, a family member or somebody might be part of that agency. And then there's some of that cultural stuff around, you know, is it appropriate for me to be accessing that particular service? So they're the two agencies that are doing that emergency and follow-up care within the community here on Brisbane North.
Thank you very much, Ged. So thank you so much for joining us today, and I really appreciate your presentation. And I actually look forward to maybe inviting you again, maybe in 12 to 18 months' time, to reflect further on where this trial has taken us, and what might be happening next.
I think it'd be great to do that, because it's a trial. We're still learning all the time, and you know, we're having to evolve through many of the strategies that we've decided are important, but we're also governed by lived experience and by what's occurring within the community. So in 12 months' time, you know, some of the things I've talked about today could be very different around how we're providing that aftercare, which I think, you know, the aftercare that people receive either from a suicide attempt or presenting with suicide ideations is incredibly important, and those systems are being enhanced all the time. So I'd love to come back in 12 months' time and be able to tell you that there's a whole range of great initiatives that are now embedded into the community and are embedded into those practices across the Brisbane North networks.
Yeah. Thank you very much, Ged. Oh, another quick question from Kerry before we wrap up. How long is the trial for? Where are we at in timeframes at the moment?
So the trial was rolled out as a 3-year trial, and it's been extended for 12 months. So those initial parts of the trial, there was that 12 months period around what does this look like? What do we need to do? So for us here in Brisbane North, the trial started rolling out at the beginning of 2018, and it's now been extended to 2020. So we have till June 2019 this year. That's the extent of the first 3-year contract that went out, and the government has announced that there has been an extension of another 12 months. So once that contract's in place, then we'll have that certainty that the trial will roll out for another 12 months after that. Hopefully, Kerry, you know, the work that's being done will be able to feed into the government systems and let them know that, you know, we need more money, and that the work that's being done in this trial needs to continue. Like I mentioned before, there's some incredible synergies that are occurring. Some of I think the great outcomes from this trial has been agencies that are now partnering together that have never partnered before and may not have partnered if it wasn't for this, you know, the seeding that has occurred from the trial. And we're also seeing agencies that haven't been able to work together before in the past are now working together, and some really strong bridges are being built, connecting those agencies. So there's those beautiful synergies that are occurring across the community, and the strengthening of suicide prevention strategies has been, you know, absolutely fantastic, a great outcome from the trial.
Yeah. Thank you, Ged. And just a reminder, everyone, that today's webinar has been recorded and that will be made available up on the Alliance's website probably early next week. So thank you again, Ged, for being here today. And thank you everyone for joining us. And I look forward to seeing you in future for our next webinar. So thank you very much.
Thanks, everyone.